The hip is a uniquely constrained ball and socket joint. While the bony architecture of the pelvis and femur provides the foundational structure, static stability relies on large volume osseous coverage paired with three critical soft tissue components. This graphic illustrates the acetabular labrum, a ring encircling the femoral head to deepen the socket. Layered over it are the capsular ligaments, acting as primary stabilizers. Deep within lies the third structure, the Ligamentum teres, connecting directly to the fovea. Together, these three structures provide static stability. Static stability is the mechanical resistance offered by joint tissues in the absence of active muscular contraction. The labrum and capsule specifically work in tandem to create a suction seal. This mechanism maintains the high intra-articular hydrostatic pressure required to contain fluid within the central compartment of the joint. During movement, the capsule restricts extreme ranges of motion to prevent subluxation, while the Ligamentum teres acts as a secondary sling to catch the femoral head at the very edges of those extremes. Pathologic failure in any single component of this triad compromises the joint's mechanics, creating a cascade effect of instability. Accurately diagnosing these failures requires rigorous MRI mapping. MRI is the primary imaging tool for direct evaluation of these structures. Its high in-plane resolution is required to depict the anatomy and pathology of these small, variable tissues. Before reaching the MRI stage, computed tomography and ultrasound serve as precursors. CT screens for osseous dysmorphisms, while ultrasound identifies tendon disease and periarticular fluid. Modern MRI protocols use three-dimensional acquisitions with isotropic voxels. Isotropic voxels are 3D pixels with the exact same dimensions in the X, Y, and Z planes, enabling accurate image reconstruction in any direction without losing resolution. This optimizes the depiction of cartilage and the labrum. MR arthrography, or MRA, offers a specific diagnostic advantage. MRA involves injecting gadolinium contrast material directly into the joint space, distending the capsule and increasing diagnostic sensitivity for labral tears to over 92% compared to standard arthroscopy. However, conventional non-arthrography 3 Tesla MRI has recently become the initial workhorse for internal derangement evaluations at leading institutions, matching MRA in sensitivity. While 3T MRI is highly sensitive for native joints, MRA remains the necessary standard for evaluating postoperative hips, detecting capsular defects, and diagnosing subtle ligamentum teres abnormalities. This illustration shows the normal morphological baseline of the labrum. In cross-section, it is typically triangular, and on all MRI sequences, it presents with a characteristic diffuse low signal intensity. The base of the labrum has a dual attachment. It spans both the hyaline cartilage at the chondrolabral junction and the acetabular bone at the osteolabral junction. On the MRI image on the right, the yellow dotted line indicates the tide mark. The tide mark is a specific zone of calcified cartilage where the labrum strongly adheres to the acetabular rim. Except for the outermost region closest to the capsule, the labrum is poorly vascularized. This lack of blood supply severely limits its capacity to heal spontaneously once torn. To standardize the reporting of tears, radiologists use the clock face method shown here. The superior apex of the acetabulum is designated as the 12 o'clock position. The 3 o'clock position marks the anterior aspect of the joint, effectively dividing the labrum into superior and inferior quadrants. Looking at the corresponding sagittal MRI, the 6 o'clock position is defined by the location of the transverse acetabular ligament. While the triangular shape is the most common, anatomic variations occur. Round labral shapes appear in up to 16% of patients, and flat shapes in up to 13%. Signal variations are also frequent, particularly in the anterior superior labrum. These can be caused by normal fibrovascular bundles or magic angle artifact. Magic angle artifact is an MRI phenomenon where highly ordered collagen fibers appear artificially bright when oriented at exactly 55 degrees to the main magnetic field. A precise radiologic read requires distinguishing these normal morphologic and signal variations from true pathology, using strict established criteria. This MRI highlights a posterior superior sublabral sulcus, a normal variant present in up to 25% of patients that is frequently mistaken for a tear. The primary diagnostic differentiator is margin morphology. The margins of a sulcus interfacing with the labrum will appear entirely smooth, whereas true tears present with irregular clefts extending directly into the labral substance. Sulci typically appear in specific locations. They are most commonly found in the posterior superior quadrant, followed by the anterior superior quadrant. Another common variant is the paralabral recess. This is an anatomical space located between the joint capsule and the labrum, and it is most clearly visualized on coronal MRI sections. When true pathology occurs, the chondrolabral junction is often the primary site of derangement, particularly in patients with CAM-type femoroacetabular impingement. Femoroacetabular impingement, or FAI, is a condition where excess bone on the femur or acetabulum creates abnormal friction during joint motion. In CAM-type FAI, continuous shear forces and compression injuries lead to chondral delamination. This is often referred to as a carpet lesion, where the cartilage peels away, coursing inward from the chondrolabral junction. This progression is visible in panel E of this diagram and MRI comparison, showing a complete labral detachment. The high signal intensity extends entirely across the full width of the labral base, completely separating it from the acetabular rim. This image shows a prominent fluid-filled cleft alongside a large encapsulated mass, known as a paralabral cyst. The presence of a paralabral cyst is highly diagnostic, correlating with full-thickness labral detachment tears in 94% of cases. In chronic cases, labral degeneration can lead to ossification within the tissue. This presents a small foci of marrow-equivalent signal intensity, and its presence can complicate surgical repair by requiring complete labral debridement. Identifying these markers matters because variants represent normal mechanical stability, while tears, detachments, and cysts provide direct visual evidence that the joint suction seal has structurally failed. Beyond the labrum, the capsule acts as a massive static stabilizer. It is composed of longitudinal fibers reinforced by three main ligaments: the iliofemoral, pubofemoral, and ischiofemoral. The iliofemoral ligament is the strongest of the three. It forms a reverse Y configuration that heavily restricts the joint, preventing hyperextension and limiting external rotation. The capsule also contains circular fibers called the Zona orbicularis. This structure forms a circumferential collar around the femoral neck, functioning as a sling that restrains joint distraction. On a normal MRI, these capsular structures appear entirely dark, registering as homogeneously low signal intensity bands. Traumatic failure of this system typically requires high-energy impact, such as a motor vehicle collision or contact sport injury, leading to a definitive hip dislocation. The vast majority of these are posterior dislocations. A posterior dislocation creates a pathognomonic imaging triad on MRI: a fracture of the posterior acetabular lip, complete disruption of the iliofemoral ligament, and hemarthrosis, which is active bleeding into the joint space. Anterior dislocations are rare, accounting for less than 8% of cases. They result from a different mechanical failure: forced hip abduction combined with external rotation. Visualizing capsular disruption on an MRI is the definitive indicator of gross traumatic instability. Recognizing this damage dictates the immediate clinical intervention to restabilize the joint. The final structure of the triad is the ligamentum teres. It is a tubular ligament situated directly between the peripheral inferior acetabular notch and the fovea of the femoral head. Historically dismissed as an inconsequential vestigial structure, modern literature confirms its active role in femoral head vascularity, nociception, and critical rotational stability. Its normal appearance on MRI is a smooth, predominantly homogeneous, low signal intensity structure, typically appearing bilobed with 1 to 3 distinct bundles. Radiologists must account for the magic angle artifact here as well. The ligament's curved attachment to the fovea capitis can artificially increase signal intensity on short echo time images, mimicking a tear. A true partial tear of the ligamentum teres presents with high signal intensity within the substance of the fibers, paired with peripheral irregularity near the foveal attachment. Complete tears manifest with full-thickness fiber discontinuity and severe ligamentous laxity. These injuries rarely happen in isolation. They are frequently associated with complete hip dislocations or abrupt twisting motions involving heavy external rotation. As hip arthroscopy techniques advance, Recognizing subtle ligamentum teres pathology on MRI has shifted from an academic exercise to a primary diagnostic priority for treating rotational instability. Evaluating a joint after surgery requires a complete inversion of diagnostic logic. The standard rules for native, unoperated tissue no longer apply. In a native labrum, the rule is absolute. Any increased intrasubstance signal that reaches an articular or capsular surface is diagnosed as a substance tear. In a repaired labrum, this rule is inverted. As seen in this image, surface signal in a postoperative labrum often represents normal granulation tissue or a fully healed tear, rather than structural failure. To diagnose a true re-tear, radiologists look for different markers. This MRA demonstrates structural distortion of the anterior superior labrum, accompanied by bright imbibition of contrast material directly into the labral substance. Re-tears are also suspected if the tissue defect extends beyond the original suture anchor zone, or if the abnormality is larger than the margins of the primary tear. Additionally, the normal paralabral recess is often completely obliterated following surgery. This replacement by intermediate signal adhesions or scarring is an expected finding in a successful repair. However, the appearance of a de novo paralabral cyst, one that was not present on preoperative imaging, is a highly reliable indicator that the labral seal has failed again. Because expected postoperative changes closely mimic native pathology, integrating the clinical context and prior operative notes is mandatory. Misinterpreting healed tissue leads to false positive reads for surgical failure. Surgical access also leaves distinct marks on the capsule. This image shows a fluid-filled defect in the anterior superior capsule, representing the unhealed site of the arthroscopy trocar portal. If the capsule was surgically repaired but fails to heal, it results in capsular dehiscence. This appears on MRI as a disrupted or discontinuous pseudocapsule, characterized by a fluid-filled gap. Osseous corrective surgeries are also highly visible. After an osteochondroplasty to remove a cam deformity, the femoral head-neck junction will exhibit a distinct, smooth, bony concavity. Conversely, resection of a pincer lesion involves trimming the acetabulum itself, leaving a visible truncation of the acetabular rim where the bone was removed. These procedures carry mechanical risks. Iatrogenic instability, instability caused by the surgery itself, can result from excessive bone removal or from leaving large capsulotomies unrepaired. Ultimately, evaluating the postoperative hip requires the radiologist to act as a forensic engineer. By precisely mapping the altered bone, the repaired labrum, and the sutured capsule, we can determine the true mechanical stability of the newly engineered joint.